We've covered a number of diverse topics in both of these sessions this morning, and we will encourage questions from the audience. So don't be bashful. Please speak up and challenge the people up here on the panel with some good questions. I'll start out with a few just to get the discussion going, and I'd like to start first with Dr. Milewicz. In patients who have the familial and sporadic type of dissections, who do you screen with genetic testing and with imaging?
So if you have a patient with familial disease, it's inherited in autosomal dominant manner, so you have to, there's a 50-50 risk of them passing on the gene to their children. So the children need to be screened, and then for the siblings need to be screened, and then whichever parent carried the mutation, those relatives need to be tracked down and screening done. So you can see once you know the gene mutation, you can exclude 50% of the people for follow-up. So once you have the gene, it becomes very powerful for determining who's at risk. Also, you can screen the individuals, and they probably need to be routinely screened every 3 to 5 years, even if they have a normal aorta, until the gene is identified for the family.
And do you use genetic screening, I mean the chemical genetic testing for all of these patients? This is expensive, and can you tell us how you implement
the costs are falling rapidly. So right now, if you order each gene individually, it's quite expensive. They've just started to set up panels of all the genes that we've identified, and that's less than the cost of a CT or MRI. So in the big picture of things, it's a relatively minimal cost, because once you have the gene, you can go through and screen other family members. That screening costs around $200 to $300 once you know the gene mutation. And then so you can identify who's at risk, cut down the amount of imaging you're doing in the family. And then also it helps inform the management of the affected individuals.
Good. And just along those same lines for Dr. Braverman, with regard to follow-up imaging of patients who've had surgical procedures, or even those who you're following who have not had surgery, what is your preferred method of screening? We're getting pressure, as most of you know, from some of the monitoring agencies, so to speak, about the cost and also the danger in terms of radiation with CT imaging. So how are we going to deal with that problem?
I usually recommend MR screening and follow-up of individuals because of the avoidance of the radiation exposure over the long term. And to echo what Diana said, as far as doing mutation analysis in patients that have Marfan syndrome or Loeys-Dietz syndrome clinically, and then you see other family members. Once an insurance company denies coverage for doing gene testing, often a phone call to the medical director or someone higher up in the organization that's refusing that, explaining the cost of continued surveillance over time, they'll often change their mind and then allow mutation analysis and pay for it. And that does eliminate a lot of patients from the worry of having the disease and a repetitive screening. I think the biggest problem is in screening the patients where you don't really know yet what disease they have or what mutation will be found eventually, and then trying to round up all those first-degree relatives and then continuing to screen them over time. But we've really gone more toward MR screening for our patients in the long-term follow-up.
Now, MRI is more expensive than CT. Is there still a role for CT? Alan?
I'm sorry?
MR is more expensive than CT. Is there still a role for CT?
Yes. Yeah, I think there is certainly still a role for CT scanning. I think it's faster, less claustrophobia. We can do non-contrast imaging for acceptable patients whose aortas aren't particularly tortuous and get very accurate measurements.
Okay. Are there any questions from the audience regarding these issues? Up in front.
I'd like to, ask a different question?
Sure.
Yeah. I'd like to specifically ask Drs. Mack and Svensson about comparing what they would predict the future of the transaortic TAVR versus the transapical approach.
So I think none of this is really known yet. One of the concerns about transapical is that it is more invasive than transfemoral, definitely. And there's a fair amount of thought that the transaortic or direct aortic, even though it's still a thoracotomy or a partial sternotomy, may be less invasive than the transapical. So I think the experience is too small to really say for sure. I think that if the transapical is going to have a significant role long term, it has to become percutaneous, and I think there's a number of closure devices that are out there now that are going to offer that opportunity. But maybe before I let Lars answer, I'd ask Rudy, because he's got experience with all the approaches here, and perhaps you could give your thoughts, Rudy.
As I said in my talk, transaortic was for us the last resort. And now there has been a revival for the transaortic access, especially here in the US. We don't favor the transaortic. I think it's more invasive, and we'd rather go for the transapical. If you're used to the transapical and once you have done a considerable amount of patients, I think it's a very safe access. So I don't really see any advantage of the transaortic. Also in terms of strokes, it's not been shown so far that there are less strokes with the transaortic than with the transapical. Also, as Mike just said, there are transapical closure systems now, and the trials will start in Europe soon. And I think that in the future we'll have some kind of endoscopic procedure to access the apex, and then we don't have to do any thoracotomy at all.
Thank you. I think it also is very dependent on what your patient has. As Mike said, if you have a patient who's on 4-6 liters of oxygen and you're doing an anterior thoracotomy, there's a price to pay for that in those high-risk patients. In the patients with really bad lung disease, I've tended to go transaortic because I think it's a quick procedure, it's very accurate, it's very easy to do, but it's obviously off-label. In the patients who are having redos and porcelain aortas, then I favor, obviously, the transapical approach. We've really had very good results with the transapical approach, and we think it's an excellent way of doing it. But I think the transaortics, they recover very quickly. They have minimal interference with breathing. The other option is the anterior thoracotomy, and on the right side, mini anterior thoracotomy, and we've used that also in the redos. But you obviously get a CAT scan, make sure the aorta is on the right side of the midline, and then that's a reasonable approach. I think with all these approaches that we're getting, including also the subclavian approaches, innominate and carotid artery approaches, you've got a lot of options, and you choose what's best for your patient. And there is, I think, a difference in stroke, and so you need to discuss that with the patients. And whether the transfemoral approach will continue to be dominant, I think remains to be seen with future studies.
Lars, while you're commenting, could you commented a little bit about the cost of the valve and the relative costs of these procedures versus open aortic valve replacement. Could you comment a little bit about the relative cost of these two procedures at your institution?
So from the point of view of specifically a transapical versus transfemorals, we did a cost analysis in 2010, and this was actual cost. This was not charges to Medicare or CMS or whatever insurance company was paying for it. We were losing $4,000 for every transapical and $3,000 on every transfemoral. So that's, in a sense, the harsh economics. Now, the price of the valve has gone up, so that has increased the cost. And we have decided as an institution that we're prepared to bear the cost, and we feel that we will continue to do what our conscience says is right for the patient. But fortunately, we have the ability to carry that. but I know that UPenn, they have done analysis there. Loss on each valve is higher than that. So it remains to play out how this eventually works out, especially the commercial side. Mike Mack and I have spent a fair amount of time trying to work with CMS, and at least initially when I met with CMS, Mike had also met with CMS, they were only going to reimburse us at the price of a balloon valvuloplasty for the percutaneous valves, and that included the price of valves. So that was hopeless. At least now the DRG is the same as for an open AVR. On the professional side, Mike's worked very hard with this, and we, with Peter Smith on the STS coding committee, we worked on the professional side. So the way it's going to work is on transfemorals. On the professional side, the payment will be 125% of an open AVR, and that is then split between the cardiologist and the surgeon. As perhaps you've seen from a draft CMS manuscript, there have to be a surgeon and a cardiologist involved with each case. So there is that on the professional side split. As a final comment about this, I think if you're going to work well with your cardiologist, you need to put the money in one piggy bank, lockbox, whatever you want to call it, so there isn't the battle on the professional fees over who gets the money, and that will make to a much more well-functioning team, which I think is critical to make this a success.
And what about the cost just for a conventional aortic valve replacement? And if there's a substantial difference here, is this going to have any impact as we move to patients that are lower risk who are being considered for either procedure?
I agree. That is going to be a challenge. As you know, there is a geographical adjustment for DRG across the country. So, for example, here in New York City, it's the DRG for an open AVR, and I've been told, is about $93,000. At the Cleveland Clinic, it's about $34,000. So we've got those parameters to work with, and the valve costs $32,500 now. How the economics play out is going to be very interesting for the next few years, and it's going to be very dependent on CMS, because the population is mainly CMS. Obviously, as we go into the lower risk, we're going to see a lot more younger patients, but it's going to be a challenge.
Okay. Question.
Thank you. Paula Chou from Paris, France. I have two questions, if you're okay with that. The first is for Dr. Kari. As we've seen when Dr. Scheffer has presented to us, when you repair a bicuspid aortic valve, when you have a better long-term result when you turn it into a symmetrical 180 degrees configuration. So, Dr. Kari, when you do your reimplantation technique with aortic bicuspid aortic valve, do you try to impose a 180 degrees configuration on your valve, or you just respect the natural ratio of the bicuspid valve?
Thank you for this interesting question. As far as I know, Dr. Schäfers and Dr. Eicher looked at valves that started out with large angles. As far as I know, you looked at large angle BAV preoperatively and did not analyze the effects of changing that angle from pre to postoperatively. And so I think there's no data on that. We actually tested that in our model, and we didn't find any positive effects of changing that angle from small to large. And what is important to know is that we looked at those angles, but it was never actually the purpose of the procedure itself was not to increase the angle.
Can I maybe correct? The angles that we analyzed were the angles that the patients left the operating room with. So it was not the preoperative angle.
Okay.
But did you purposefully enlarge the angle from pre?
Yes, ever since we realized the effect of the commissural orientation, we've made an effort whenever we replace the aorta, whether you do it with sinotubular junction remodeling or root replacement, to increase the angle, to go as much towards symmetric as possible. Even if you achieve 160 degrees, that's already in terms of durability, an advantage compared to the 140, sometimes even 130 degrees that one occasionally sees.
Could I just add a comment? I think the critical aspect here is your height of apposition of the leaflets. That's what you really got to work on, apart from not narrowing it down so you get aortic valve stenosis. We just analyzed 780 of our bicuspid valve repairs, and what's interesting is that after that initial 1-year period, what determines outcome late is a progressive over time increase in gradient, and it's a virtually linear relationship. So when you do your repair, you need to be very careful that you end up with a valve that is not stenotic, because if it's stenotic, that's going to increase over time.
Thank you. My second question is for Dr. Scheffers. When you do your remodeling technique plus annuloplasty, you stabilize the sinotubular junction and as well as the annular junction, the annular size. Have you ever seen in your long-term follow-up any aneurysmal dilatation of the subcommissural part of the aorta, especially in Marfan patients, for example?
No, not yet. However, I have to admit that our follow-up in using this type of procedure for connective tissue disease is shorter than that of Dr. David. We are still carefully following the patients. We submitted a first paper to the Journal of Heart Valve Disease, and it should come out soon, showing the results of both approaches. Up to a mean follow-up of 6 years, they're identical. Of course, for these patients, it's important to have a 10 and 20-year follow-up. So I think we need to discuss this question again in 10 years.
Thank you very much.
Thank you. Yeah. I have 2 quick comments and a question. There's a question about CT versus MRI for surveillance or even initial imaging. I just wanted to point out that I think that there are going to be continued innovations in imaging and its impact on how we approach the care of patients with aneurysm. Specifically for us, we are using a technique called retrospective gating that has increased our diagnostic yield of type 1 bicuspid aortic valves dramatically in our own program. So I think that's pretty exciting. I wanted to comment to Dr. Carl regarding the late finding of progressive aortic insufficiency after root replacements. I saw this initially also after using 36 millimeter grafts for my roots. And I think it's because these Dacron grafts dilate somewhere between 10 and 15% over the early postoperative period, and that may be why you're seeing early dilatation. When we reduce the size of our root graft, now I use 34s, sometimes 32s, we're not seeing that so much anymore. But my interesting question is for Dr. Milewicz. I was wondering if you thought that there's any danger in assigning risk simply based on finding genetic mutations in these patients. I'm the furthest thing from a geneticist, but I feel that at some point we're going to be able to identify some genetic abnormality or difference in every patient with aneurysm, and I wonder if it's a little premature to simply assign risk based on finding a gene mutation. Thank you very much.
So there's clearly genetic variants that confer a high degree of risk, and those include, you know, the mutations in FBN1, the TGFBR1 and 2 mutations. And so I think there is a group of genetic variants where they really do clearly define a high risk for thoracic aortic disease. Now, at the same time, within the FBN1 gene, there are genetic variants there that confer no risk for aortic disease. And so it does get very complicated when you're trying to analyze genetic data. And then if you take a gene like MYH11, there's clearly variants that cause thoracic aortic disease and other variants that do not cause thoracic aortic disease. So I do think that we have to be careful as we analyze these variants and make sure that we're dealing with a disease-causing variant. Geneticists know how to do that analysis, and that's why I urge you to send your patients to a geneticist for genetic testing, because it's not as easy as ordering the test and understanding the results immediately.
Thank you.
Diana, if I could just pose one question. We've talked a bit about this in the past, but there are a lot of professional athletes now who are very tall, and I've had 4 NBA players, a couple of NCAA players who are obviously very tall and don't look like Marfans, but they have big roots, and we've had to operate on them. Any thoughts about what we should do genetically about these patients and testing, because it has obviously huge implications for big sportsmen?
That's a tough question. I do think they do need to be tested for the known genes. I still think that there's a lot of these marfanoid plus aneurysm genes that we haven't identified yet. The testing is in part because of the risk for other family members, and in part because it does help determine management to some extent.
Let's get back to the question about sizing of grafts. Tyrone, maybe you can comment on this. You've had several different ways that you determine the size of grafts when you do a valve sparing procedure. Tell us what you do currently.
I try to estimate the diameter of the sinotubular junction and go from there.
So if the sinotubular junction is 22 millimeters, what would you pick for a graft?
A 22 millimeter graft, but I would not do reimplantation in someone who has a 22 sinotubular junction.
So essentially now you don't use any of your formulas, you just estimate the size of the sinotubular junction?
I do not.
You do not.
But I do worry about size of the annulus versus height of the cusp. There is something I call in the operating room mismatch between sinotubular junction, annulus, and size of the cusp. I mean, you don't have to be a mathematician to realize that if the annulus is larger than twice the height of the cusp, something is badly wrong with the valve. There's a mismatch between size of the cusp and size of the annulus. So you have to reduce everything to compensate for the size of the cusp. So I do not ignore the size of the cusp. Patients with very small cusps are usually elderly with sinotubular junction dilated as a primary mechanism of aortic insufficiency. Those patients require a simple operation, either only adjustment in sinotubular junction or at the most a remodeling. And they come up with small grafts, 22, 24 grafts.
Now for the reimplantation procedure, you commented on the fact that you use the cylindrical grafts more commonly now. You used to use larger grafts and pleat them and tuck them and so forth. You don't do that anymore?
No, I don't. It's more bleeding in the operating room, more little holes in the graft. And to be quite honest, the longest follow-up we have is in cylinder. They have the best outcomes. And I said only passing, it looks like the younger the patient when you do the operation, better the long-term outcomes. Likely because the cusp may have adaptive mechanism to a rigid root than a patient who's 60, and the cusp is no longer elastic.
Right. I'd like to just show one slide here for a moment, if I can, that kind of relates to what you're talking about. This is a patient who initially was thought to have Marfan syndrome. We operated on her 15 years ago and did the David procedure. She was subsequently found to have Loeys-Dietz syndrome, and about a year ago, 15 years after this procedure was done, she sustained a dissection after pregnancy and had to have a repeat procedure. But this is a photograph of that implanted valve at 15 years, and you can see that the leaflets are absolutely perfect. And this is in a cylinder graft. Now, can I ask any of the other panelists here their techniques for sizing grafts when you're doing the reimplantation procedure?
What we do is quite simple to size the, I know from some study, from echocardiographic study done by Scheffer's team, that more or less the sinotubular junction diameter equal to the height of the sinus of Valsalva. So what we do is, after deep dissection of the aortic root, I draw a line between the nadir of the left sinus and the none, and only size the height of the posterior commissure. It is 30, 32, 28. I take 30, 32, 28 diameter.
But geometrically correspond to sinotubular junction.
Yeah. I mean,
so it's the same thing.
Exactly.
It's geometry of cylinder.
No, exactly. I mean, for me, the sinotubular junction is the most important thing. So size, one way to size the sinotubular junction is to size this height, which is very objective.
Dr. Carl?
The formula introduced a couple of years ago by Feindel and Dr. David, taking the aortic lumen times 2 times 0.67 and then adding twice the aortic diameter, the tissue thickness. That's used as a complementary method to intuitive surgeon, the intuitive surgeon's choice, I think. But it's still it's used at Stanford.
Now, Dr. David mentioned that he doesn't use the Valsalva graft. You want to tell us about your feelings about the Valsalva graft? And do any of the other panelists use a Valsalva graft in this procedure?
I take a look at the anatomy. Aortic root is not a spherical. Aortic root is a cylinder with 3 spheres or hemispheres to make the sinuses. Gebrin had a beautiful slide of a cadaveric root with no sinuses. What shape was the Gebrin? Cylinder. Read all the work that Francis Robichek and Manu Tubricar wrote 20 years ago on anatomy of the aortic root or geometry of the aortic root. Cylinder. 3 cusps suspended in a cylinder with 3 bulges. Valsalva is a sphere. You're deforming the aortic annulus. I'll bet you 10 years from now I'm going to be sitting here and say, yeah, he was right.
Anybody on the panel use the Valsalva graft?
I use the Valsalva. I mean, the way you work on the Valsalva tube by scalloping and aligning the commissures to the Valsalva can help us to make this kind of three sinuses. If you put it like it is as a cylinder, and then so we will have really a cylindric root. But if you work on it and really align always.
Yeah, but he placated in so many places worse than a dog's breakfast in the end to make a cylinder. So use a cylinder and placate great sinuses.
Yeah. But I mean, the only thing was it's easy with the Valsalva that when we are doing the second plane, it is very easy to work with the Valsalva. When you want to place the 3 commissures, it's very easy. You know, because there's a lot of discussion, how much should we extend the straight tube or whatever. Valsalva is easier to work with.
Well, let's ask the others. Dr. Sievers, Dr. Svensson, Dr. Mack, what's your preference?
So I use it, and I'm afraid to admit it right now. But I feel better because Rudy uses it also. Do you want to comment, Rudy?
Yeah, I don't dare to get into another fight with Thyron, of course, because we have discussed this many times. We use exclusively the Valsalva graft, and altogether we have about 200 patients now. Maybe 50 of those have a straight tube, and 150 have Valsalva graft. And as far as to date, we don't see any difference at all in the long-term outcome.
I never use.
Sorry.
I'm sorry.
Go ahead, Lars.
I've had to reoperate on a couple of patients with the Valsalva grafts, and I tend to lean towards what Tyrone has been saying. And I've seen these patients come back with 4.5, 4.7 roots, and the leaflets get pulled apart. I don't use, and I haven't used it for that purpose. I think it's a great graft for biological composite valve grafts. I haven't for that reason. But as far as sizing, I looked at Tyrone's paper and thought, you know, am I really going to calculate this on every patient? And then I saw he was mainly using 30-millimeter tube grafts for most of his patients. And so that's what I use for most patients. I use a 28 for a smallish woman. And for, you know, professional play or something like that, I might go up to a 34. And then the other thing I do is the Hay gauze. I use that formula based on body surface area and insert a Hay gauze. I think that's much more important as far as long-term durability, and you want to have at least 3 to 5 millimeters of apposition long-term and to maintain good function of those leaflets.
Dr. Sievers, briefly.
I don't use the Valsalva graft. My feeling, this is intuitive, my feeling is that the operation must include optimal height of the commissures. You have to place them as high as possible, and I've done a number of reoperations from other centers where commissural height was the primary problem. The Valsalva graft limits me by definition in where I should the highest point where I can place the commissures. This is why I prefer the tube graft, because it's unlimited. I can simply place the commissures as high as I want.
Yeah, good point. Let's go to the audience.
François Bouchard from Rouen, France. I'm asking a question about the aortic, the root dilation. If you have a young woman, 16 to 18 years old, with a Loeys-Dietz syndrome and an aortic root about 42 millimeters, you plan to change it. Where do you stop on the aorta? We have in our team good results with the surgery of the aortic arch, especially in a non-acute setting. And why not changing the aortic arch? Would it seem outminded?
Duke, Cameron, you want to respond?
Well, there isn't really enough experience to comment on that. I did mention in my talk that in the younger Loeys-Dietz patients where we didn't replace even the entire ascending aorta, there was a small remnant of distal ascending aorta proximate to the innominate. There was some dilatation in these patients that we really haven't seen frequently in Marfan patients. So I think, you know, a more aggressive replacement of the aorta makes some sense, but I think you've got to be able to do an arch replacement with a very low operative risk to justify an approach like that.
Question.
Ziad Hanhan from Jersey City, New Jersey. I have a clinical question, hypothetical situation. A 30-year-old woman with a type A dissection that's limited to the ascending aorta. She has a bicuspid aortic valve, and the aortic root is 4.5 centimeters. Which operation would you perform? Would you go for the Bentall or prophylactically, or just replace the ascending aorta, if you could?
Receivers?
A small woman, 4.5 centimeter root, means that this is markedly enlarged. There is not published data, prognostic data, showing the degree or the likelihood of root dilatation in that patient. On the other hand, if we index it for patient size and then apply common sense, I think one can make a strong argument in favor of root replacement, whether it's a Bentall replacement or maybe a valve-preserving replacement.
Just to follow up, is that a consensus? For the community cardiothoracic surgeon who can do a Bentall but also could lower the risk by just replacing the ascending aorta in an acutely dissected situation, I'm just trying to get some controversy here.
Save the patient's life. Do the simplest possible operation so she go home alive, and then send somebody else to do above sparing later on.
Thank you.
Yes, question.
Good morning. My name is Luca Botta. I work in Niguarda Hospital, Milano, Italy. I have a question for Dr. Alkuri and Dr. Schaffers. I would like to know from there if there is still a role for selective replacement of non-coronary sinus in a bicuspid valve in patients with dilatation of the ascending aorta and the bicuspid valve.
While Jibreen is thinking about the answer, I think, but this is completely personal, no. Why don't I do it? We don't have good information on the ascending aorta, but we know from the aortic isthmus then that whenever we introduce prosthetic material in an asymmetric fashion, and I'm thinking of the patchplasty that was done 30, 40 years ago for coarctation repair, this resulted in a relatively high incidence of aneurysm formation. For that reason, even though at times it looks like the non-coronary sinus is the main problem, I prefer to do a symmetric operation, that is, replace all sinuses. Having said that, it's often proposed that the one sinus is larger than the others and the operation should maybe include only that one sinus. At this time, I'm not aware of any long-term data showing that there is a disadvantage in doing it.
I agree totally, but I think one of the first things to think about is the age of the patient. If the patient is quite old, 50, 60 years, or I think replacing the non-coronary sinuses can be a good idea, because the aortic ventricular junction is stable and there is no risk for further dilation at the level of the aortic ventricular junction. If the patient is young, 60, 20, 25 years or 30, I think we should be more aggressive and do symmetric reconstruction of the aortic root.
Thank you. Thank you.
I'd like to ask Dr. Lang, you showed some data showing that, indicating that the percutaneous valves now are approximately 30% or so of all the valve replacements in Germany. Is that reduce the number of open aortic valve replacements, or are these in addition to the standard aortic valve replacements?
No, the statistics show very clearly that it reduces the amount of open procedures. And this trend has started about 2 years ago. There was a plateau for 2 years, and now it's decreasing.
By what percent would you estimate?
I would say by maybe 10%.
10%. Question.
Yes, I would like to ask Dr. Milowitz, I may have missed the answer, but I mean, in the setting of an aortic surgery program, whenever a patient comes with an acute dissection, do you recommend genetic counseling for all these patients? Or do we have to have some family history or something of dissection or other?
So I think if the patient is young or there's a family history, genetic counseling is warranted. The treatment guidelines state that you need to go through and work up the family members, but that can be done by the cardiologist.
So if we don't have any apparent family history according to the patient, do you still send him for genetic counseling or not?
If the patient is young, and I would define that under age 50, 55.
Thank you.
Question up front.
Ogino from Tokyo Medical University in Japan. My question is to Dr. David, Nell Corey, and the Schaeffers. And my concern is about the cusp repair technique. They just actually two techniques, the central application and another technique, which reinforcement, which Dr. David said, and Dr. Corey said, that lead suspension. So for what pathology, aortic cusp, both techniques are suitable?
The video I show is representative of a normal cusp.
Yeah.
If the cusp is normal in thickness, I think plication is the way to go. However, if the free margin, you can see that is overstretched, is paper thin or thinner than paper even, then I reinforce the double layer Gore-Tex, one very close to free margin, and a second layer Gore-Tex a few millimeters below. 2 years ago, when I gave a talk on this here, I showed a video on how we do it, and I showed the result of a patient who had Gore-Tex 13 years earlier and came back for reoperation because of a mitral valve repair. And we explored the aortic valve. You cannot see the Gore-Tex anymore. It's identical to Gore-Tex in the mitral chorda tendina. Becomes totally covered by fibrous tissue and reinforce the free margin. And I think Gebrin, who I trained 15 years ago, he took this to a new level. To be quite honest, I was very conservative initially. By watching him do much more freely, I expanded the indication as well. And you have published this over 100 cases now. It seemed to stabilize the cusp. My point was, by doing this, you expand the indication of aortic valve sparing, particularly in younger patients, people under 40 or 30 years of age, where you don't want to put a mechanical valve and keep them anticoagulated for a lifetime.
Duke, let me ask you a relevant question that relates to this. That is, your current indications now to use a mechanical valve in a patient with either Marfan syndrome or Loeys-Dietz syndrome. I mean, when do you decide to use a mechanical prosthesis and a composite graft?
It's essentially only if the patient has requested it up front. And we still have some patients who have other family members who have composite grafts who've done well with them, and they actually ask for another mechanical valve. The other patients would be those who've already got a mechanical mitral in. But most of the patients who are not candidates for valve sparing usually ask for a biological Bentall as their backup.
Have you had to do repairs of many of the leaflets in this group of patients?
In the Marfan group, it's about 10 to 15%. And in our group of patients, the commissures are so thinned that we've really not been able to do free edge suturing. So we'll do a mid-leaflet plication. I think only one of those Loeys-Dietz patients had a mid-leaflet plication.
Question.
It's Manu Martha from Sydney, Australia. With the valve-sparing routes, most of these patients have got mild or minimal AR, or most patients have got severe AR? Because the patients with the root aneurysms with the severe AR, you look at the leaflets and think this is not going to give a good long-term result. But I'd like to know from all the panel, severe AR, what proportion of their cases have actually got severe AR when they're doing the valve-sparing route?
You saw in our slides approximately half of our patients had moderate, and 1/4 had severe AI at the time of the operation. I don't think severe AI means bad cusp in patients who have aortic root aneurysm necessarily. It means the root is what I said before. There's a mismatch between surface area of the cusps and the orifice the cusps have to seal. Some cusps tolerate very well, other ones fall apart. I don't want to convey the message of repair every aortic valve by a long shot. We still do 4-to-1 Bentos in Toronto versus valve sparing. So it's not that common. These are highly select patients. But if the cusp is prolapsing, we fix them if the substance is reasonable.
If the root's over 6 centimeters, are you still doing valve sparing?
Even 70 millimeter or 80, doesn't matter. All depends on the cusps.
Right.
Remember, sinus valve dilatation does not cause aortic insufficiency. What causes aortic insufficiency is annular and sinotubular junction dilatation. You can rupture sinus valve in the right ventricle, like children. They have competent aortic valve, and there's a hole in the sinus, and the valve stays competent. So you can have as big as you like sinus valve. The two things that play on the functional aortic insufficiency is sinotubular junction and diameter aortic annulus.
You said in Toronto it's 4-to-1 root replacement versus valve sparing.
Yes, we do about 120 Bentos a year.
So
only
why
25,
aren't they having valve sparing roots, those patients?
I'm sorry?
Why aren't they having valve sparing roots? Why aren't they suitable?
They're bicuspid calcified, they are bad aortic valves. We can repair some of the Marfans. They come, the cusp are all destroyed. In those, of course, you replace them. The whole key is the quality of the cusp. If the cusp are in reasonable quality, I think it's a good and lasting operation.
Dr. Schaefers.
In our experience, roughly 70% of the patients have either grade 3 or grade 4 aortic regurgitation, maybe even a little more. I don't have the exact figures. I think it's a good question insofar. As a rule of thumb, if there is minimal regurgitation, there is also minimal alteration of cusp geometry. If there is relevant aortic regurgitation, there is a very high likelihood that you end up with prolapse of at least one, if not more, cusps. So when there is severe aortic regurgitation, you go for a valve-preserving operation. You must expect cusp prolapse. You must familiarize yourself with the techniques of assessing cusp geometry and of correcting the prolapse.
I would add to what Tyron was saying, that as far as size and regurgitation amount by itself, those are not reasons not to do a David reimplantation. In our population, we looked at this a while ago, 5% of our patients had 4+ AI, so that's not a reason to exclude the patient. The big question is if the fenestrations are there and how big they are in the leaflet. So once again, as Tyron was saying, the leaflet quality, if you've got good leaflet quality, then you can always repair the valve if need be and then do a David reimplantation, and you don't have to replace it. So that, as other people have said, it takes judgment over time to decide which patients you can keep their leaflets. The other thing I would say as a rule of thumb is if there are more than 2 leaflets that are prolapsing, you probably shouldn't try and do a David. In those patients, that usually doesn't work out. If there's 1 leaflet, that's very easy to to correct the prolapse, and 2, you can, if it's, you can hitch up one commissure to do it and reimplant it at a higher level. But once you've got 3 leaflets prolapsing, then it's usually not going to work.
Question.
Syed Awal Aziz from Cairo, Egypt. My question is for Dr. Khouri and Dr. Shafers about patients with bicuspid aortic valve. Sometimes we are faced with patients who have a mild stenosis, not an insufficiency alone, with a gradient of 40 millimeter maybe or 50. In such a case, do we proceed for valve sparing also, although there is a mild stenosis with those patients and there is some calcification in the leaflets? What to do about this? The second question also is about using the annular stabilization, if there is a difference between the stitch Gore-Tex or annular ring.
I mean, for the gradient, the whole issue is the quality of tissue. You can have a normal bicuspid aortic valve with really a huge dilution of the aortic root and big gradient. Now, if you do sparing surgery, the gradient will disappear because you have more motion of the leaflet. The question is different if the leaflet are calcified. And now, I was quite aggressive some years ago. Now I'm become a little bit less. And if the bicuspid valve is calcified, I will replace the valve. Not really, unless it is really localized calcification on the raphe or the base of the leaflet. So gradient per se is not really a contraindication, providing that you have a good quality of tissue. If there is no calcification, we do. Now, regarding the annuloplasty, I mean, for bicuspid valve or tricuspid, my preferred technique for stabilization is reimplantation. Now, I never tried the Gore-Tex stabilization. The only comment I can do that when we are repairing the bicuspid valve, we like to have a, let's say, selective annuloplasty of the anterior part of the bicuspid annulus. I'm not sure, and I will ask Jochen to have his comment, that with the circular annuloplasty, there is no selective effect. We are reducing the whole circumference. I don't know if I'm right or...
Maybe let me answer the second question first. At this point, I have not seen, in terms of root geometry, a disadvantage of the circular annuloplasty through the suture. Early on, we had a couple of complications. This was when we used the Ethibond, and we had 2 or 3 patients with secondary erosion of the membranous ventricular septum. This is something that, of course, you will not expect or cannot expect when you do a David operation. This problem seems to be largely eliminated by just changing the material. On the other hand, I said this is early, it's early results that I presented today, and probably we're not dealing with the ideal implant yet. My vision is to have an implant that you can pass through muscle that has a bigger diameter than that suture and therefore a better stress distribution. To come back to your question regarding the gradient, I was similar experience in the past. I thought it's very easy to cut out the calcium suture in a patch or just peel off calcium if there is a calcific bar. I have become less enthusiastic about this. Insertion of a patch into, for instance, the area of the median raphe is an independent predictor of failure, and I've become very conservative regarding insertion of patch material in a bicuspid valve. It's different for a tricuspid. And the only 2 patients I had to operate for aortic stenosis 10 and 11 years after remodeling of a bicuspid valves were patients where I peeled off a limited calcium bar from the non-coronary cusp at the initial operation. Now it was a durability of 10 or 11 years. At the reoperation, the valve was completely calcified. So probably a bicuspid valve that already shows calcifications at the time you touch it is not a good substrate for valve preservation. Does that answer your question?
So you proceed firstly from the start to change this valve?
Yes, today if I would operate and I see calcifications, if it's a very young patient and I can go by just resecting the calcium and by making the aorta smaller, I still have enough tissue left, I would go for direct readaptation. If there is more extensive calcification, I would strongly recommend replacement.
Okay, thank you.
Question.
Jean Bachet from Abu Dhabi. The previous question leads me to rise and ask Jebrin and Hans Schäfers. When we see your results and your video, it seems very simple to repair those valves, but I'm convinced that it's not so simple, otherwise it would be much more popular. And you are speaking about decalcifying, etc., etc. What exactly is the proportion of the patients with an aortic valve problem that you repair and that you replace in your departments? This is the first question. And you said, for instance, that the quality of the valve, that's your words, the quality of the valve is the only criteria. How do you appreciate that? Is it just a highball? You look at the valve and you say, this is a good one, this is a bad one? In other words, what are your objective criteria to decide, I will replace this valve or I will repair this valve?
Can I answer first? Proportion of repair in our total volume is 37-38%. It was up to 40 a few years ago, and then we became a little more conservative on some of the bicuspid valves. Objective criteria, one is calcification. This is what we commented on. Dr. Svensson also mentioned the presence of multiple fenestrations. My feeling is 1 or 2 fenestrations can be closed, and it's more complex, a more complex procedure. But if there are 3, 4, 5 fenestrations, I think that valve is better replaced. In addition, there is the important and interesting question, cusp retraction for rheumatic valve disease, which I think is a suboptimal substrate for repair. If we look into the literature, and currently I'm fighting through the editorial comments with a publication that I submitted to the JTCVS, looking at cusp height, at what I call geometric height, just the amount of tissue. A normal tricuspid valve has a cusp height of 20 millimeters. If it's 17 millimeters in an adult patient, this cusp is also already retracted. And for the bicuspid, it's similar. The one large cusp, the mean is 23, and if it's 20 millimeters, it's borderline less than 20 millimeters. That amount of tissue is so little that I would recommend not to go for repair or only considering it's retracted, and these valves we would then go for replacement. Jebrin, you want to comment?
I mean, we have the same, I agree totally with him. The only thing that I can say that if you have an aneurysmal problem and you have the echocardiography assessment and surgical assessment, any patients with aneurysm as normal valve usually is preservable 100%. Now, patient with aortic regurgitation, problem is a little bit different. Now, depends on the quality of tissue for sure, but what is really most important, more important in the quality of tissue at the end of surgery, not when you discover the patient. Let's say if there is a small calcification, small thickening or something like that, and you can resect it and restore a good motion of the leaflet, and at the end of the surgery we had a good results, I think it's
a number. Huh? Give us a number. By the way, so for us, 40% for total volume, 85% for regurgitation. Jebrin, you say the same numbers. Total volume repair and repair in regurgitation percentage.
Yeah, 80 to 90%.
Does age interfere in your decision? In other words, if you have a patient of 70, would you spend time in repairing his valve instead of putting a nice pericardial valve, which will take 45 minutes and which will last 20 years?
I mean, depends on if it is dilated root, you will do a Bentall, and so there's that big difference in time. between ventral and sparing surgery.
I'm not speaking of dilatation of the root. No, I'm just subject.
If you have only prolapse of the non-coronary of the right, I think with 2 stitches you can finish the operation also. So I think if you are confident in your technique, you can do repair, you can do whatever. I mean, there is not really that. The major problem is to be confident in your surgery.
Let's take one last question.
Carontona from Milan, Sac Hospital, University of Milan. I come back to the free margin reinforcement with the Gore-Tex. Is an excellent technique, but I think that today we can use it only for an anatomical stabilization, not for the physiology of the valve, because we demonstrate that when you obtain a good coaptation, the valve, the free margin, is completely distressed. And this is the reason, because you can placate, only placate to resolve a prolapse without reinforce the margin, the free margin, and you have excellent results on the time. It means that we can reinforce the free margin to resolve a small prolapse, but not to stabilize the valve. It's only an anatomical stabilization, because with the finite elements we show that the valve is completely distressed. It means that, on my idea, the most important problem is to have a nice coaptation, more than 4, 5, 6 millimeters for coaptation.
I agree entirely. You restore anatomy first, and then if there's 2 or 3 large fenestration, you are concerned it's going to rupture. Doesn't matter how good coaptation you have. If my slide represents well, the one I showed you, a very large fenestration that extend to the central portion, that kind of cut should be repaired or the valve replaced. So yes, placation central portion to repair prolapse, but in addition to that, the cusp of bad quality, reinforce a Gore-Tex, a 7.0 Gore-Tex, 2 or 3 layers sometimes. It's going to guarantee a longer durability for the repair.
Because some time ago we spoke about the bridge suspension of the bridge was this is the meaning before. Now I think that something has changed. Only anatomical stabilization.
No, I never use Gore-Tex to correct prolapse. From day one, from my very first publication, if you read, I said I use Gore-Tex to repair large fenestrations. Prolapse is repaired by plication. You can correct a millimeter or 2 prolapse by suspending a bit. But if prolapse is half centimeter, you should not rely on the Gore-Tex to fix the prolapse.
Well, our time is up. I want to thank all of the panelists for their presentations and comments, and the audience for your attention. We'll reconvene at 2 p.m.